Hi there, I'm Dr. Eric Heffron from the Impact Institute and Impact Physical Therapy. I'm a physical therapist and I'm super excited to present this information on the function of soft tissue. So we're going to dive deep into understanding the physiological principles and components and characteristics of soft tissue, how it plays such a vital role in the human body, and how our manual therapy and cupping and other interventions can really play a drastic role in the soft tissues. It's really important to have a base foundation of understanding of soft tissue to truly understand kind of what our hands are doing during myofascial release or what's happening underneath the cup when we're doing myofascial cupping. So this is going to be a great lecture. We're going to talk about a lot of just different terms, and hopefully by the end you'll have just a much better understanding of how soft tissue works, and more importantly, when you're putting your hands on your patients or clients, what's happening underneath when you're doing those treatment approaches. All right, so there's four primary tissue types of the body. We got one, epithelial tissue. So that's our skin or tissue of protection and secretion and absorption. Two, we got muscular connective tissue, and that's using contraction helps the human body with that is through the muscular system. And then number three, we have the nervous system, which is sensation and conductivity. Just like the lymphatic system, the nervous system is intertwining into our entire body, and through the fascial sheets and diving deep into our muscular system and into our skin, so it's everywhere. And then lastly, which we'll go deep in today, is connective tissue. So connective tissue helps to support, helps with nutrition, helps with defense of viruses or infection, helps with balance and movement, and definitely shock absorption. As ground reaction forces are pushing up through the floor into our body and gravity's pushing down on us, connective tissue really has to be very resilient and to hold our body into the right postures and allow us to move the right way. So that's kind of where we live a lot, and as far as movement professionals is looking at especially connective tissue as a component of what we're doing on a daily basis. All right, soft tissue. I love this cross section. We have just a cross-sectional view here of the femur and the surrounding soft tissues. We have the fibrous tissue and ligaments and tendon in there, and the fascia interweaving into all components of tendons and ligaments and muscles. We have skin along the outside and a layer of fat underneath that, synovial membranes, muscles, nerves, and blood vessels. So wow, that's a lot going on there. I love the picture here. It's something nice to refer back to when you're working with your patients. And just understanding that, everything but bone is soft tissue. And we can really make a drastic difference on our patients if we're applying the right kinds of forces and the right angles and giving them the right kinds of exercises, how we can affect those soft tissue components. And all of those soft tissues just vary slightly in the chemical makeup. But just knowing that with the right kinds of forces that we can truly make a change, and it's pretty awesome what we can do with our hands and what we can do with cupping and some other kinds of great treatment approaches that there are out there. All right, so soft tissue function, as you can see, there's a whole bunch of different areas that soft tissue works in our human body. It can provide pathways for nerves and blood vessels and lymphatic system. There's fascial planes that help divide the soft tissues up. A matrix for the organs and the structures of the body. So just thinking about that our organs and the anterior part of our stomach is all comprised of soft tissue, and great ways to get in there and mobilize soft tissue to help even release organs and help with digestive function too as well. There's a lot of visceral therapists out there. And some of you might have a training in that, and just the importance of fascial and connective tissue that lines our organs. A whole bunch of other activities, as you can see. I'm not going to read it line by line, but just a great way to understand how the soft tissue can function in the human body. All right, so the recipe of connective tissue. So if we're building a recipe and we want to make connective tissue, there's two primary areas that are essential in the ingredients of soft tissue. So we have cells and extracellular matrix. And cells are just kind of the living functional units within our biology. There's many different types of soft tissues, of cells. But one thing that we want to highlight is fibroblasts, and so those are the most common cells of connective tissue, and they secrete fibers and ground substance. So fibroblasts, you want to just think of how they work. They build things. So depending on what kind of fibroblasts, we can categorize those either osteoblasts, so they make bone, or chondroblasts that make cartilage. But it's important to understand that fibroblast activity is happening constantly within our body, and it's important to know that how the fibroblastic activity works. As we're holding ourselves in certain postures, whether that's if we have a forward head and rounded shoulder postures, those fibroblast activity within the upper traps and scalenes and maybe pecs could be active in creating a new matrice, a new almost body form, if you will. So that's important to know. How we're going to turn those fibroblasts on and off, and how do we remodel properly. And then we have extracellular matrix, which are long strands of collagen fibers and ground substance. So this matrice is almost like a jello-like substance, and that's why I put that on there. This gelatinous but yet strong matrices that help bind and make our connective tissue. All right, so properties of soft tissue. We have a colloid, which is a property of soft tissue, and it's solid particles suspended in fluid. So the properties of colloid, I want you to think about, as we increase, or let's just read this. A colloid increases its resistance the faster a force is applied. Amount of resistance is directly proportional to the velocity of the force application. So I have a picture here to the right that just shows a gentleman pushing his hand through mud. And what you can think of when you're thinking of colloid is that, if we're applying our manual therapy fast and quick through the soft tissues, whether that we're using a cup or even our forearm or our hand, we're going to get more resistance back from the tissue. So we must apply forces that are slow and that are deep enough to actually make a change in the connective tissue. So if we go fast and really quick with our manual therapy techniques, we're going to get a lot of pushback from the soft tissues, and we may not actually make a difference. It might just be, just really just more of heating up the tissue. It actually can be uncomfortable to the patient. So I really want you to, on this slide, just hit home that when we're doing manual therapy, really apply the forces to the tissues at a good, nice, strong oblique angle to the tissue, but also at a slow rate. So I can't emphasize that enough, a slow rate. Otherwise, you're going to get pushback. Another example is if you had like plaster. Plaster is just another kind of material that some of you may work with if you've had art in the past. Though, if you're working with plaster, that when it's in that wet kind of gelatinous type state, if you're pushing through really fast, you're going to get a lot of resistance through that material. But if you go nice and slow through that at a good rate, that you'll actually make a more of a change. Your hands will actually be able to, and fingers will actually be able to slide through that material. So think of that with soft tissue. The last term down there is trixotrophics or trixotrophia, and that's the response of tissue change with temperature. So you have to think of that ground substance is when we're cold or first thing in the morning, that substance is more of a gel type. It's a little bit thicker and doesn't move quite as well within our soft tissues, but that transforming gel can turn into liquid if we warm it up. So that's something to think about when we're working with our patients, right? Is that we need to warm up the tissues before we apply our manual therapy techniques to make that much more of a difference. We'll be able to move fluids around much better, and that can come in the form of riding a bicycle, walking on a treadmill, being on a new step. We can apply a hot pack. We can use our hands to melt the tissue. So I would urge you to do that if you're going to dive right into manual therapy, to melt the tissue for a period of time to warm up that. And that would be that trixotrophic principle that we're thinking about. And then applying, cupping or applying our hands in myofascial release. All right, so here's another slide on properties of soft tissue. You can see the pictures to the right of two men pulling a rope, and then the bottom one is more of an elastic rubber band. So collagen's kind of like that rope. It's definitely the most abundant protein in the body. The structural and functional integrity of it is very strong, and it helps kind of provide just a nice, stable response to our tissues. And it's responsible for the colloid properties that we were just talking about. Collagen is, has tensile strength, similar to almost steel wire, if you will, and it provides that structural and functional integrity, especially with tendons and ligaments. So that's just a nice picture there to the right to show just a depiction of collagen. And then we have elastin. So soft tissues also, has elastic properties. So it's the springless resilience or give in order to withstand deformation when a load is applied. So we must have a balance too with that elastic type property, and so that rubber band is to depict more of an elastic tissue. In this last little bit, mechanical energy is stored through the mechanical stresses applied to them. Use this to return to original shape. So with some of our manual therapy techniques or cupping, it's really important to add therapeutic exercise after that, because we really want to make more of a plastic long-term change when we're applying some of the manual therapy principles. Otherwise, it just may come back to its original shape. And that's why it's a little different, and we're a little different than massage therapy, that our soft tissue is going to be a little deeper. It's going to be a little more purposeful to address some of the ailments along the fascial chains. But then we're also, is where the movement part of our degree is that we're going to add the therapeutic exercise to complement our manual to really just have that new shape and create long-term results. And the last thing with elasticity or collagen too is that we must know that our forces must be applied pretty deep to make a change. So if we're warming the tissues up and melting it, and we're doing thinking about trixotrophy and warming up the gelatinous material, that's great. We're probably not making a change though in the actual connective tissue as far as making a deformation there. We must kind of apply a decent amount of force to make a widespread change in breaking some of those connective tissue bonds. So what I like to use kind of as an analogy or as a scale is a 0 out of 10. So if a 10 is me applying like a Graston tool as hard as I possibly can, creating bruising and just, I'm going as deep as I can, that's probably a 10. And a 0, or let's say a 1 or a 2, might be a nice little effleurage, melting the tissue, warming up the ground substance. Well, where we want to kind of be in that range is maybe around a 6, 7, or 8 to make a real change in those soft tissues with our patients. So know that sometimes when we're doing manual therapy or cupping, we might need to start out at a 1, 2, or 3, depending on their hypersensitivity, depending on their connective tissue and the properties of what we're feeling, but then building up to a little bit deeper to make more of a change, and then lastly, supplementing our exercise just to keep it long term. All right, hysteresis. Heat and energy exchange between the tissues as they deform. So the process of energy storage and energy loss, this is kind of the possible explanation of myofascial release and neuromuscular therapies, as this exchange of energy between the tissues to cause them to deform. Then we have physioelectric effect. So looking at the microscopic level, we're looking at connective tissue that's subject to mechanical stress molecules as they shift and electrical charge is produced. So there's constant push and pull, stress signals, fabricating the structural changes. Another example of the physioelectric effect, just think of somebody with severe rounded shoulders and forward head posture. Over the years, as we get older, sometimes that kind of occurs. But just think about the molecules as they kind of are cued from this push and pull of stress signals that they receive from local forces, and just how they respond to producing mechanical transduction and that physioelectrical current, meaning just, our body even at the electrical level is making changes depending on our postures, depending on our environment. So it's pretty awesome just looking at it even at the electrical and microscopic level of soft tissue and even, molecularly what's happening. Lastly, plasticity. Effective or frequent load overcoming elastic properties leads to plastic changes. Consider slow applied manual therapies as semi-plastic changes. Right? So with some of that plasticity, we've heard of low load, long duration stretching. Same thing applies with some of our manual therapy techniques. We just must have a slower, deeper change to the tissues that we're applying. If we want to have this more of a semi-plastic or plastic changes, if we go too fast, we don't go deep enough, and we're just too quick, then we might just have more of that elastic type change where everything kind of goes back to the resting length. Okay, fascia. Love this part. So fascia is comprised of all those soft tissue principles that we talked about in the previous slides, but if you remember back in undergrad or if you ever worked in an anatomy lab, cutting through the skin and You know, if you were like me, you're just excited. You're trying to get down to that muscle or bone or look at the tendons and ligaments. So you're cutting the skin off, and then that white just kind of packaging material, you were cutting that off and throwing it in a bucket down below. At least I was. So, our knowledge of fascia has changed drastically over the last decade. And before, we just thought it was packaging material, didn't really have much function, just more of like an insulation underneath the skin. But wow, there's more fascial research in the last 10 years than really in any other area, and so many research articles out there. But fascia forms this continual and tensional network through the entire body, covering and connecting every single organ, every single muscle, and every single muscle fiber and nerve. So if you think of a muscle fiber, that's wrapped in fascia. The muscle belly is wrapped in fascia. Connecting muscles to muscles is fascia. And we're learning that there's at least 3 or 4 different kinds of proprioceptors that live in fascia. So it's live, living tissue, guys, and it's so important to understand kind of its principles and how that plays a role in just the whole human function. A lot of times when we're looking at anatomy books and even anatomy class, the fascia is removed, and so all we're seeing is just origin and insertion of muscles without actually just seeing what fascia, how it overlays all the muscles and connects each other. When we really see that, then you can get a better appreciation of how one area may affect the entire area. So when we're doing cupping or any other kind of myofascial techniques, we must think about the whole fascial trains and fascia itself, and not just thinking about a specific injury site or muscle belly, but looking at the entire kinetic chain. So the roles of fascia, they help to maintain our structural integrity through this thing called tensegrity, which is just a tension network through our entire body, and support and protection. So a good example of that is if we were to have an infection in our calf. The fascia lines those different compartments so that bacterial infection, let's say, doesn't spread into other compartments. It wards that off, which is pretty awesome. As a shock absorber, so as ground reaction forces are pushing through our body, fascia just helps absorb those forces in hemodynamic processes, in defense and communication exchange process, and in biomechanical. So as you'll learn today too, and through the live lectures that we're coming in with, is that you'll learn that, again, one area of a fascial distortion or fascial issue will cause a biomechanical issue in other areas, whether that's, a foot issue may cause a left hip or right hip issue, could cause a low back problem too as well. Fascia is very adaptable. It can change, again, to the forces and environment that's placed upon it. Its increasing physiological strain will adjust fibroblastic matrix remodeling activities such as tissue architecture better meets the demand. So this is a great example that I want to talk about, is if you've worked with paraplegic patients, spinal cord injury, let's say, then you'll notice that the tissue integrity and the matrices of that tissue, let's say along the IT bands and glutes, is going to be much more flaccid. You're not going to feel maybe quite as many adhesions or tight bands of tissue versus somebody that's walking. So a bipedal patient or person that's weight bearing, and even you just listening to this lecture, if you're running down your fingers down the IT bands and into the gluteals, you'll notice just what the tissue integrity is like. There might be just a little bit more tightness, and those are demands of gravity and ground reaction forces on our body. And those fibroblastic remodeling cells are very active in those areas because, again, they're always constantly, adjusting based on our environment. We can look at somebody that's like an equestrian rider or a horseback rider. The adductors, because they're using that constantly to hold on to the horse as they push their knees in. Those adductors might feel a little bit more band-like or tight, or adheres down a little bit more. The muscle demand, might be greater, obviously, there, so there might be some hypertrophy. But the tissue is going to be different there. And that person, again, just another example of how our environment or what we do and the stresses that are placed upon them will change those soft tissue components. The good news is that we can change those soft tissue principles. Soft tissue can be very adaptable, as we were talking about earlier. It can be changed through our hands, through cupping, through exercise. It's just got to be consistent. It's got to be the right amount of pressure. But then we can actually morph that, almost like Play-Doh, into what we need it to do. Here's a video I want to play just to show you how fascia is live and living.
With rings that reinforce the solidity like an articulated bamboo stem. transparent sails, dewdrops. Travel along these pearly structures, and you notice the same fractal arrangement everywhere. Large fibrils endlessly punctuated by other smaller ones. The tissue continuum is total, the marriage homogeneous, and the arrangement completely fractal. A world of fibrillar chaos. The human body would seem to be one and the same tissue that has differentiated over time, but whose basic organization is stereotyped. Yet this organizational framework supporting life must have its inherent rules of behavior. How are these structures organized? How do they resorb and move, and what?
Awesome. So you can see that is a great video of what fascia looks like underneath the skin, without being embalmed like a cadaver. That's what live living connective tissue and fascia looks like underneath the skin. So you kind of have to almost erase the memory of just that normal anatomy, straight sagittal plane look of muscles, just origin into insertion, and think more about this video of this whole fascial just network and tensegrity and this liquid gelatinous material that's omnidirectional, connecting every muscle and muscle belly and nerve. So that's kind of what true anatomy it looks like. All right, so let's talk about anatomy trains. Tom Myers coined that term. He's got a whole system of anatomy trains. I highly encourage you to do some personal research on that and find out more about some of the fascial trains. But Tom Myers, did this global line of this tension system through the whole body and mapped out these fascial sheets that run in different areas of the body that just kind of help just shape our skeletal system and available movement, helps us with just postural patterns. So it's pretty cool. So when we do some of the assessments in lab, I'm going to show you just different ways to kind of assess the fascial system. And if we were to take something down here as an injury to the anterior tib, how might that distort or affect something along this anterior chain into the stomach, into the opposite arm? We must think about a body as a whole, not just as an affected area. So taking the time with our manuotherapy and exercise can really make a difference through that anatomy train. So just summarizing some of the lessons from anatomy trains, just summarizing some of the stuff that Tom Myers has looked at, as he shows that this myofascial just kind of a continuum must run in like these straight lines. So almost like these sheets, these superficial and deep sheets of fascia running through our body in different lines, which we'll go over, the anterior and lateral lines. Whereas muscles are more just discrete, there's just specific origin to insertions. Well, fascia is more continuous. So, not just looking at one muscle to muscle, but how fascia can connect muscles to muscles, and how if you lift your arm, you're not maybe only using the deltoid or the pec, but how because of fascia, how the serratus and other muscles may be activated and pushing and pulling in this tensectional or tension network. Fascial planes can divide or blend in with deep tissue. Their deeper single joint muscles can hold the posture. So we'll talk about just some of the fascial trains that run deep. And when the rules get bent, you get derailment, meaning if one area is affected, you're going to affect that whole fascial train. So let's look at some of these in a little bit more detail, at least visually. So here's a superficial front line. As you can see, the fascia runs from the bottom of the top of the foot here, the anterior tib, quads, and all the way up to kind of through the abdominal and even into the head. So, somebody with a total knee replacement on the left side here, think about what's happening underneath the skin to the fascia as it's pulling possibly this superficial front line. So they may have a hip tension issue down into the foot here, maybe even into the other side. So think of the body as a holistic area, not just a part. Then we got superficial back line. So here's a whole fascial sheet that runs from the plantar fascia up to the calf and the Achilles, into the hamstring, up into the sacral tuberous ligament, into the lower back, paraspinals, into the back of the head. So pretty awesome, right? So as we're learning, which is kind of cool, and more PT research, they're showing, hey, with plantar fasciitis, maybe address the calf and think about how that's all connected. Well, let's take that even a step farther with the superficial back line. Plantar fascia, calf, Achilles, hamstring, maybe low back. How can that all be affected, right? Let's not just stop here. Let's go all the way up the whole kinetic chain and make a difference with our cups along that chain, with our hands, with our stretching, with our assessment tools. Here's the lateral line. Obviously runs through the lateral part of the body, through here, through the glutes. You can see the IT band kind of runs deep to the ribs and even to the neck. So, if a lateral line's affected, it could be affecting, again, all the way up the kinetic chain. Here's the spiral line, so more of a spiral type pattern, kind of looking like the anterior one that we saw, but just crossing here and running deep into those deeper structures. And then we have the arm line, which is awesome. So you can kind of see this is a whole fascial plane. Let's look at the pec here. So, it's pretty cool with some of our patients and clients that we work with, even with carpal tunnel, or some issues down into the hand and wrist here. Well, this is a whole fascial sheet that runs into the pec and actually into the other side there. So when we're thinking about treating an area of an issue or pathology down here, we must consider the whole fascial sheet and fascial line. As Tom Myers dissected out, he found this whole arm line that's all interconnected. So that's something to think about, again, when you're working with your patients, is not just the area of local issue, but how is the whole kinetic chain affected? If they're having radicular symptoms, is that not only getting caught up maybe at the nerve root, but through that fascial sheath, through that fascial tensional area? So that might be something that we need to work on. We not just the carpal tunnel, but the biceps, the pec, even into the other side of the pec to make a difference down here in the hand. Then we got the functional line that runs deep under the anterior part, as you can see, through the abdominal area, those adductors into the pec. Something else to look at. And then the deep front line, so very, very deep fascia. This is another just adductors and running these fascial lines that Tom Myers found too as well. All right, so let's talk about principles in driving some of our interventions. When looking at Hooke's law, we're looking at the stress that's imposed on the tissue, or the degree of force that's being applied is, remember, directly proportional to the strain produced within the elastic limits of the tissue. So looking at elasticity, right, something can be stretched, there's that force that's applying to it, stretching it out, but an equal force that's kind of pulling it back into its normal elastic component. So soft tissue is the same thing. And remember that stress-strain curve that you're applying a force, but after you get to a certain point, you're not going to get that elastic kind of return that you're going to have maybe plastic changes. And then Wolff's law, really important to understand. Really with that one, right, if you don't use it, you'll lose it. And which means with bone, right, if we want to have somebody with osteoporosis get stronger, we must load the bone and the muscles that connect to the bone in order to make the bone stronger. Otherwise, if we're not using it, then the bone will get reabsorbed and start to develop osteoporosis, osteopenia. So if we want to get stronger, we must have a new force applied. If you're always sticking to 2 sets of 10 at the same weight, well, you're not really looking at Wolff's law, because we're not really changing that force to make a change. So that's something to think about with therapeutic exercise. Are we constantly changing the load for the patient to make some physiological changes in the bone and the muscles? And that would be using Wolff's law in that scenario. And then soft tissue healing. Boy, you guys remember this graph, I'm sure, at some point in your life. I don't know if it brings up bad memories or something good to refer back to, but I highly suggest thinking about this when you're working with your patients and clients. And I love the quote up there: the basis of all treatment techniques lies in the understanding the basic process of soft tissue healing. Doesn't matter if we're doing therapeutic exercise, Mulligan, Maitland, we're doing manipulation. Just understanding what phases is that patient going through. Where are they in this spectrum here? Are they more in that inflammatory state, in that cell proliferation state, or more in the matrix remodeling? And remember that these phases kind of blend together. There's not always necessarily a beginning and an end directly, that they kind of blend in with each other. So looking at, inflammatory state, are they, very inflamed? Does an injury happen, surgery or an injury? And, within that 0 to kind of 10 days, there's all that bleeding. And, what are our manual therapy interventions? How is cupping? How's that going to be affecting that person that's in that inflammatory state? I think if somebody comes in and they're really inflamed and have a lot of bleeding and swelling and edema? Are we going to go super hard with our manual therapy and our TheraX? Probably not, right? Because we want to kind of get them. We want to get the swelling out of there, right? Good fluid in and good fluid out, so that they can get into that kind of that second cell proliferation phase, where they're starting some of that angiogenesis and fibroplasty and all those kinds of things that you see listed there, collagen coming in, and then of course remodeling, and some research is showing that it could take up to a year for remodeling. So, with our exercise programs, or even manual therapy, maybe they need to be having something more long term. That 4 weeks isn't quite enough. We start to see some strengthening changes, but that remodeling is lasting up into a year, and that's something that we need to educate our clients and our patients with. The other thing I want to talk about is that really what we're applying with our manual therapy or cupping, we're having the body heal itself, really. We're just adding an external stimuli so internally that they can heal. We're not actually healing them. So the better healing that they have internally, the better results they're going to get. What are some things that we can do to educate them on nutrition, on taking care of their body, hydration, the way that they're thinking, their thoughts is going to change internally, how they may heal. So if you've worked with kids, I can tell you what, they'll make you look good. Athletes, somebody that's got a really good internal healing mechanisms in there is just going to heal and get better much quicker than a patient that has tons of comorbidities, on lots of medications, that are very, very sick. Some of our manual therapy and our things that we're doing just may take some more time, and we might need to do some more educating. All right, hydration. If you're listening to this, go ahead and stop a minute, chug a big glass of water, because our fascial tissues need it. We're 2/3 comprised of water. Some studies, or people say, hey, you're 80% water. I think the hit home is that we're made up of a ton of water. Our fascia needs water. Our joints need water. Every chemical process in the human body needs water. Most patients that come in, I would guess a lot of them at least, are dehydrated, especially if you're working in a rehab or subacute area. They're on tons of medications. These patients are stressed out. They're not in the same environment that they're in. All those things cause dehydration. So, like I was saying, prescription medications cause you to be dehydrated. Caffeine, so that's like soda, teas, energy drinks, those all dehydrate us. Stress dehydrates us. Obviously, living in Arizona, the heat can dehydrate us. So it's very vital to make sure, if we're really wanting to make a change in soft tissues, that we're hydrated. And that's something easy to educate your patients on if they're not having any restrictions from their physician as far as intake with water. But it's and some people will say that good guideline to use for hydration is half your body weight in ounces. So let's say I'm 200 pounds, I need about 100 ounces of water a day. That's just normal. Now I may need to supplement more of that depending on if I'm a big coffee drinker. I drink a lot of soda pop or alcohol. Those things dehydrate me. For every 8 ounces of caffeine, you need to supplement that with 12 ounces of water. So one classic example that I'll see is that patients will come to me and say, man, in the morning I'm so stiff, right? I'm just bound down. That plantar fascia is really restricted. My lower back, man, is stiff when I get out of bed. Part of that is dehydration, guys. So our tissues aren't hydrated. They'll say, oh, once it's warmed up, man, it's better. That's because it's hydrating the tissue. It's very, very common. So, but like most people, you'll stumble into the kitchen and make that pot of coffee. So we wake up, we're already in the red, we're dehydrated. Then we drink that coffee, and that places us more in the red, right? We're more dehydrated. Then we might drink one glass of water, still in the red. So some suggestions I'll say is when you first get up in the morning, chug 2 glasses of water. That'll get those tissues kind of hydrated and loosened up, and then have your coffee and so on. So, just read this slide, and, just important, just hit home that water is so key for the function of our body. And, as we're doing manual therapy techniques and we're pushing some of that, bulk water in those areas out, we want a new, just fresh, hydrated, fluid to go back into those tissues as this kind of pumping mechanism. Almost like, imagine a sponge that you put in water, and as you push the sponge, water comes out, and then as the sponge is in the water, then it reabsorbs new water. So it's kind of the same thing with our tissues. Here's just some more on hydration. Talk about 99%. I was just telling you the body's chemical reactions require water. So important, not just even for connective tissue, for brain function, for energy. There's even some research out there that's showing just some of the brain function, if you're dehydrated, what that can do to you. A lot of people are walking around drinking energy drinks, and they assume that it's actually going to make them have more energy for the day, but that's actually dehydrating you. So it's going to, affect you, long term. And so I urge you to drink more water. The last one, if fluid is reduced, increased sympathetic reflex activities causes pain, or pain can follow. This is expressed by increased tissue resistance locally and even globally. Just saying that if we're dehydrated, that's going to affect our tissue resistance with our hands. And that working with your patients, you're going to get more resistance and bounce back in the tissues. It's going to feel more like beef jerky when you really want it to feel just like a plump, just medium rare steak, not this beef jerky type material. So something easy to educate your patients, and even for yourself, drink more water. All right, so looking at tissues and the aging process, I love this chart here. Younger characteristics and older characteristics of tissues. So as you can see, younger characteristics, it's going to be more fluid and less fluid. Obviously, as we age, some people will say the aging process is dehydrating. Right, our disc heights get smaller. The synovial fluid in our joints gets more dehydrated. We start to develop osteoarthritis. It's a dehydrating process. If you've had kids or in the past, or you have a youngster right now, I imagine my 2-year-old daughter back in the day when she was, in the back seat chewing on her toe. I mean, think about the elasticity that's in her tissues and that fluid that's in those tissues that will allow her to be more flexible. And as we age and those fibroblasts are really, taking shape, our body starts to become a little bit more tight. When we're younger, there's more collagen, there's greater elasticity, more fibrocartilage as we get older. Mineral count is lower. There's less calcium when we're younger. More deposition of calcium as we get older. Increased local elasticity when we're younger, and decreased mobility as we age. Right? These are all stiff as we get older. All common things, especially if you're in the rehab setting. You're probably not seeing any children at all. You're seeing all elderly patients. So important to understand kind of what their soft tissues are going with, are happening. So what does that mean with some of our manual therapy or cupping? Well, to me that means might need to warm them up a little bit with our hands. Take a little longer to warm up. Whether that's using a bike or something, or our hands with manual therapy, just to get the fluids moving a little bit better instead of just jumping into something right away. The pressure that we apply might just be a little bit more gradual and working in deeper, just because their tissues are a little bit more, you could say, frail, or just not as elastic as if you're younger. Soft tissue behavior. Soft tissue should translate or glide with one another, or adjacent structures, right? They shouldn't be sticky or adhese down or are bound down. They should just be a nice slide and glide. Again, if they're dehydrated, they're going to be a little bit stickier. They're not going to slide as well. Or if there's an adhesion or injury or scar, they're not going to slide as much. Trauma can cause binding down and then create an abnormal state. You'll see that total knee replacement. Tissues are bound down, not even locally, but globally too as well. Tissues are not sliding and gliding like they should. Binding can put pressure on nerves, muscles, bones, organs, and connective tissue. So we don't want binding. Binding's not good. That'll just create a whole bunch of havoc in the body. Extremely adaptable to physiological loads, changes architectural demands to meet increased demand. So the demands that we're putting on the tissue, the loads that we're putting on it, will change the architecture of the soft tissue, whether positively or negatively. That's something that we need to think about as we're just sitting in a chair and having that rounded shoulder posture. Those fibroblasts are kicking on, changing the architectural demands, increasing the tone in our muscles, creating more dehydration up there. So we need to make a change. All right, so let's look at fibrosis versus scar formation. So with a scar, it's a kind of a clear-cut stages. It's very linear, and there's a complete beginning and then an end. I get a small paper cut, and then there's an immune response that happens, and new tissue lies down, and then it's done. It's complete. But with fibrosis, the entire tissue area is affected. It's cyclical. It's not linear. It's cyclical, and it continues as long as the irritant is present. So with fibrosis, if I have an injury and I tweak my neck and I'm sitting in horrible posture all day long, well, that starts to over time become chronic and the entire tissue area is now affected. And then if the irritant is still present, meaning my body position is just horrible, and I'm hurting, then that'll continue that fibrotic process. Here's a great little graph that I love to see. As you can see, there's some sort of irritant that's happening. These macrophages are activated coming into the area. Obviously, you're getting increased vascularity, increased fibroelastic activity, increased production of connective tissue. Fibrosis starts to happen, right? Those fibroblasts, increased myofibroblastic activity, and then you get this shrinkage of the connective tissue, and then obviously an abnormal movement. And this just continues as the irritant is still present. Round and round, the circle of doom, if you will just continue. How are we going to break that process? How do we, as physical therapists, or occupational therapists, or whoever you are out there, how are we going to break that process to not allow this to continue to happen over a period of time? Well, that's where we introduce dry needling, or boom, we introduce cupping there, or myofascial release, or strain, counterstrain, or manipulation, or we change that sort of movement issue, an irritant that's happening to make a change. Otherwise, that fibrotic process will continue to happen. That's something else to ask too, right? Is the chronicity of it. It's obviously a little harder and takes a little longer time if somebody's had an issue that's more chronic, because this fibrotic process is happening much longer, and so now you're taking their body's taking new shape, and that new fibrotic tissues laid down, and it might extend globally into now not just localized to the traps, but now into the rhomboids and down into the paraspinals. And so it's just another important thing to educate people on, is that when you get injured, you got to see a physical therapist immediately, just so it doesn't turn into something more chronic and this fibrotic process just continues to go. All right, physiological effects. We're looking at a trigger point. So a trigger point is kind of like this, deep band of muscle that's just bound down, not only just mechanically, but also chemically. There's this, it's more acidic in this chemical environment. So this trigger point's, the longer that it's there, can create more hypoxia to the area, lack of oxygen and fluid to that area. So it's important that we get in there with our cups or our manual therapy techniques to release those trigger points, so that bound down, irritant is being removed, and we're making a change, and it's not going through that fibrotic process. And just saying on the left here, activation of a muscle spindle reflex results in relaxation of contractile tissues and retaining of myofascial structures. So we need to get that muscle spindle to relax, and cupping is a great tool to do that. If you find a trigger point, you can put a cup on there and allow that muscle spindle to kind of relax, and then allow the muscle belly and the connective tissue and fascia in that specific area to relax, and get some better blood flow to the area for healing, because sometimes it can be very hypoxic, especially how long they've had it. All right, for all you people that love like cross sections and microscopic slides, this is just a smaller picture of a tendon. It's a dense, regular connective tissue. You just kind of see what a fibroblast nuclei looks like in those collagen fibers there. We're going to just look at how a scar tissue is formed in muscles. So, we got a bigger muscle tear to the left, number one there. And as an injury like whiplash or a sports injury happens, the body then senses that tear, and then it repairs, right? It lays down this new collagen right here, the fibroblastic and just, activities happening. It lays down new collagen. But that's something to think about, as collagen, remember, as we talked about before, is very, steel-like. It's very tight. It's very strong. And after injury, that lays down to protect the wounded area. But sometimes as it lays down like wet spaghetti and all over the place, and just very tense. So we need to go in there with our manual therapy techniques and make a difference to that. We'll get a lot of patients in our clinic. They'll say, you're doing a subjective history. They'll say, man, I strained my hamstring a long time ago, and they just didn't get any therapy for that. Now they might be coming in, let's just say, for low back pain or sciatica. Well, sometimes it's important, as we're learning now, right, with all the principles that we've learned so far, that new connective tissue laid down when they had the hamstring strain, but no one ever really went in there, broke that tissue up. And so now you're getting this widespread, could be fibrosis or tightness through the glutes and then into the lower back, maybe pressing or compressing on that sciatic nerve. So when we use our hands in manual therapy, we may discover that. And so it's not just necessarily going to the sciatic area or the low back. We might need to go into that where that hamstring strain was, release that tension, help release that whole fascial train that goes into the back. Just one example that we can use here when we're thinking about muscular tears. Because a lot of times people just have these minor injuries and not go in to actually get any body work or therapy for them. All right, let's look at cellular level changes in soft tissue. So here to the left, you see the pre-injured healthy tissue. Look at all that nice red, just hydrated tissue there, of a pre-injury healthy tissue. Then we look at an injured tissue. It's kind of more strained. You see it's a little bit more bound down. And then now look at the healed scar tissue. So like we were using that hamstring analogy or story previous slides, just think about that all intertwined in there and what it's doing to the just whole chemical process and soft tissue process and fascial chain. So we must go in there and use something like cupping to help break up some of that scar tissue and break up some of those restrictions. Well, hey, I thank you so much for listening to this lecture, listening to me talk for 40 minutes or so now about soft tissue and its characteristics. But I really, truly hope that it builds a little better foundation as a manual therapist or as a movement professional out there. I hope it just helps give you a better knowledge of the properties of soft tissues, the characteristics, and what's going on with our patients when we're putting our hands on them. How our forces should be applied when we're doing cupping or myofascial release. Whether we need to be warming up the tissues to melt them or using a slow, lower load, longer pressure to make more of a physiological change. Understanding fibrosis, how that may affect the whole kinetic chain and those fascial trains as Tom Myers described. So go into this world with a little bit better knowledge, hopefully, a little bit better understanding how the human body works and how soft tissue works and how we can make just huge changes on our patients and clients. So thank you so much and good luck.